Okay, so hello to all our audience, urologists, oncologists, and also our medical colleagues from China and the Chinese-speaking world. So I'm your host, I'm Dr. Rin Zhang, and today we are so honored to welcome a world expert in urothelial carcinoma management is Professor Brian Rennie from Vanderbilt Cancer Center. He has published numerous high-impact academic papers and also led in multiple international multi-center clinical trials. So just Brian, would you mind to say hi to our audience?
Yeah, hi. Thanks for having me. It's great to be here.
Okay, so over the next hour, let's follow Professor Rainey's perspective and delve into the core, controversials, and cutting-edge directions in MIBC management. So before we officially start the conversation, Brian, so I want to brief you, for the clinical status of the urothelial carcinoma here in China. So according to the latest epidemiological data, the incidence of the urothelial carcinoma in China is on the rise. It's about to 80,000 to 100,000 new cases each year. It's accounting about, I think, maybe the one-fifth of the global new cases, I think. So it's a huge market. And mostly, and the urothelial carcinoma in China has two distinct local characteristics. I don't know whether if you know that the one is a unique risk factor is the aristologic acid exposure. It's related to the UTUC and also related to the renal dysfunction, and which also cause, for there is so many herbs and also the Chinese traditional medicine, they will have the ingredients of the aristologic acid and which lead to the urothelial carcinoma. And second is the late diagnosis for the for the urothelial carcinoma here in China. So about 30%, 30 to 35% of the patients who are diagnosed with MIBC here in China. So maybe we have the more high proportion of the MIBC, and which leads to our first topic of this conversation. As just as you know, the adjuvant therapy, it seems to be a key link, to reducing the risk from the recurrence after radical cystectomy. So first, I would want to ask you about selection of the adjuvant therapy for the patients after the neoadjuvant therapy or with the data of the EV303 and 305, and right now we have the EVP regimen. So first of all, for the patients who achieved pathologically complete response with YPCR patients. For these patients, it seems to be the most population who benefit from the neoadjuvant therapy. For these patients, what do you suggest or recommend for them to receive further adjuvant immunotherapy or other therapy? So in your clinical practice, and whether there is a core evidence basis for decision making?
Yeah, so EVP neoadjuvant we're just starting to do, right? Based on the
Yeah,
ESMO data and soon to
yeah,
be, there was a press release yesterday about the
sure.
cis eligible population from the other trial. So we're in my clinical practice, we're just starting to do it. So, my default answer would be that we should give the regimen exactly as it was given in the trial, right? We
Okay.
should give
Yeah.
3 cycles beforehand and then 6 cycles after and continue the pembro for I think it's a year
Okay.
total, so I haven't deviated from that. I think the question is really around not so much path CR versus everybody else, but maybe for patients who don't respond at all,
Yeah.
who are persistently ctDNA
Mm-hmm.
positive or have node
Mm-hmm.
positive disease. I think that's going to be,
Mm-hmm.
I haven't encountered it in clinical practice yet, but
Mm-hmm.
I think that's a tougher patient population. I think the path CR patients clearly are sensitive to therapy. They've clearly responded.
Sure.
And so,
Sure.
I suppose you can make an argument that they don't need more therapy, but that's not really how the trial
Sure.
was done. So if it was me, recurrent bladder cancer is a nasty disease, generally
Yeah.
life-threatening. And so I think I'd probably just say, unless there's some toxicity that prohibits it, I would want to, finish out the regimen, so to speak.
Okay. When we are doing the clinical trials, in the EV303 and 304, okay, we'll give them another like the EV and with pembrolizumab. But if the patients were achieved YPCR after neoadjuvant chemotherapy in your clinical practice, would you recommend immunotherapy for these patients, or we just have the surveillance?
I mean, I think I would still recommend therapy. That's the regimen
Okay.
that led to the big
Hmm.
survival
Hmm.
advantage. So it's hard to say that they
Yeah.
don't need therapy. That experiment hasn't been
Okay.
done.
Hmm.
I kind of doubt it will be done. There's another trial called Volga, which is testing neoadjuvant CTLA-4 inhibition as well, and that just gives neoadjuvant
Hmm.
and not
Hmm.
adjuvant. So if depending on how those results turn out, it's a similar population as the 303 and 304 studies that um, you could compare across trials and say, gee, what is the adjuvant period really adding? Because adjuvant immune therapy has really only showed a disease-free survival benefit, right?
Yeah.
Checkmate 274 with nivolumab
Yeah.
and the Atezo and trial was negative. There was Pembro trial. So there's some data for
Yeah.
single agent adjuvant immune therapy,
Hmm.
but it's not overwhelming. It's not overwhelming data. But, it's just the imperfections of different
Hmm.
trials that do it differently. But we can't, I'm generally stick to the data and stick to giving the regimen as it was given. I think what's going to happen in practice is, there'll be some patients who just can't finish the EV. They just run into
Hmm. Yeah.
toxicity. And so, that's what
Yeah.
happens in the metastatic setting. I have
Yeah, yeah,
a
yes,
pretty
I think
good,
maybe medium cycles for these patients who received in the EV303. For these patients who received the adjuvant EV is the 3 or 4 cycles. I think
yeah, I was
maybe
just thinking, I don't
this
remember the
medium.
number if they said it
Yeah.
during the presentation, but
Hmm.
it wasn't nine or
It's
10. And
toxicity limited. Yeah.
that's my experience. I've given
Okay.
much more of this in the advanced setting, in the last year or
Okay.
so. And
Mm.
I have plenty of patients who only get a dose or two of EV and have to stop and then
Okay.
continue with Pembro and do really well. So, how
Okay.
much EV you need, I think is an open question.
Okay, so in your global view, it's you're pro for the immunotherapy, adjuvant immunotherapy, but the cycles for the ADC drugs is still it remains a no.
It's, we only have the data we have, right? But it's
Yeah.
probably,
Okay.
again, I don't know if it'll ever be really well studied. It's probably the kind of thing that'll just work itself out in clinical
Mm.
practice more than, be another randomized trial or something.
Okay. So, and the second question is, we have a population who received the neoadjuvant therapy, and then we can see a partial response in some studies. These patients who are downstaging to the YPTIS or the T1 disease with negative lymph node. For these patients, there are several studies suggest that even though this patient is not responded to the neoadjuvant therapy, but in some studies, this seems to be a more, to be a better prognosis compared to these patients more than YPT2 disease. For these patients, and would you suggest adjuvant therapy for these patients, adjuvant chemotherapy or adjuvant immunotherapy, or would you in your clinical practice, were you using some like molecular characterization or some performance status to help you for the
I
decision
mean, I
making?
think I think it depends. If this was an EV Pembro neoadjuvant patient, then again, I
Mm-hmm.
would give them adjuvant therapy.
Yeah, yeah,
If
sure.
it's somebody who got, gemcitabine cisplatin for whatever
Mm-hmm.
reason,
Mm-hmm.
um, and had just TIS or T1, then I would not give them adjuvant therapy. I don't
Okay.
think the Checkmate 274 didn't include those
Mm.
patients. I
No.
haven't given a ton of, again, putting EV Pembro aside, I haven't given a ton
Mm-hmm.
of adjuvant immune therapy in bladder cancer.
Okay.
Some,
Mm-hmm.
for patients at higher risk, et cetera.
Mm-hmm.
But I wouldn't say routinely. I think I'm not
Okay.
sure what the uptake in the US has been, but so it's definitely
Mm.
out there, it's approved, but I don't necessarily give it to every patient. I just,
Okay.
I don't see a ton of these patients, but I think that's a more difficult question. If they had
Yeah.
EV Pembro neoadjuvant, well, then I think it's an
Yeah.
easier one, right? Because the
Yeah.
data is much more compelling with an overall
Yeah.
survival advantage.
Okay. So the third question is for the patients not respond to the neoadjuvant therapy. For this patient remains to have the more than YPT2 or the lymph node positive disease. So right now we have several evidence suggest that this patient should receive the adjuvant immunotherapy with the checkmate and checkmate 274, and also there are several studies. So is there a several space, whether there is remains to be controversial? Maybe there are some patients who are not benefit from the immunotherapy. So in your clinical practice, would you have some patient selecting for these patients not
For
responding
those
to the
patients,
neoadjuvant
I mean,
therapy?
again, if they didn't get neoadjuvant therapy or got just
Hmm.
plain chemotherapy, then yeah, I think those are the patients who are really high risk for recurrence, and I'd probably
Yeah.
lean towards giving them therapy,
Hmm.
adjuvant
Hmm.
single agent immune therapy.
Yeah.
Again, I think it's more challenging if you had somebody get EV
Hmm.
Pembro, and I don't know how many of
Okay.
these, how many, node positive patients at cystectomy they had on that study. I can't imagine it's that many. But,
Hmm.
if you give somebody a regimen and they still have pathologically positive nodes, they clearly didn't respond to that regimen.
No.
So it's a little hard to give them the same regimen afterward. It's also a little hard to think that they're going to benefit from single agent immune therapy if they got immune
Yeah.
therapy before surgery. So I don't know. I don't know how many of those patients
Hmm.
were in the EV303. I don't know if it was reported. I got to imagine it's pretty small, but
Hmm.
I think we'll start to see trials that take those patients and give them different
Hmm.
regimens. I
Yeah.
would think,
Okay.
again, I'm not aware of trials specifically, but I would think that's a population of patients that obviously needs different therapy and novel therapy.
Sure.
And again, I'm not sure how
Sure.
common it is, though. It might be hard to do a trial in that setting.
Okay. Okay. So let's talking about a little about the liquid biopsy. So we can see that in the adjuvant chemotherapy, in the adjuvant therapy setting, right now we have several strong evidence, to support we using the liquid biopsy, the ctDNA, using for the decision making to decide which patients should receive the adjuvant immunotherapy with all this data and the in vigor or 1-1, and also with the codex the data from the checkmate 274. And so I want to ask, do you routinely use the ctDNA right now to guide your adjuvant therapy or adjuvant immunotherapy in your clinical practice right now?
I mean, I haven't, but I think with the IMvigor11 and 274 data presented at ESMO, I think I will.
Hmm.
To me,
Okay.
the most compelling is, those negative patients do
Mm.
really well.
Yeah.
Their
Hmm.
recurrence is low, their survival is great, so it's really
Yeah.
hard to justify
Hmm.
giving those patients adjuvant immune therapy. The chance
Yeah.
of them benefiting, it's hard to
Yeah.
benefit when 9 out of 10 people aren't going to have recurrence anyway, right? So
Sure.
I
Mm.
think I think those patients, can safely be observed, and then
Okay.
obviously treated with whatever if they are the rare
Sure.
patient who has
Hmm.
recurrence. Um, and similarly, on the other side, I think, the positive patients obviously have a much higher risk of recurrence. And so in any adjuvant setting, you want to enrich for patients who benefit. And in
Hmm.
this case, it's a prognostic marker. So if you are ctDNA after surgery, or I guess within a year after surgery, according to IMvigor11, then you're obviously at much higher risk of recurrence, and intervening in those patients can show a difference. Again,
Yeah.
it's just the
Okay.
unique nature of the adjuvant setting where some patients will never have recurrence. You can't possibly benefit
Okay.
those patients by treating them. You can
Yeah.
only harm them. So,
Yeah.
so yeah, I think that's going to be pretty
Hmm.
routine. Having said
Okay.
that, again, we don't know how to incorporate that with neoadjuvant EV Pembro. So if you get
Okay.
neoadjuvant EV Pembro and cystectomy, and then you're ctDNA
Mm-hmm.
negative, does it mean you don't need more therapy? Again, that's not how the trial was done. But you
No.
can envision some people doing that. I'm not saying it's right,
Sure.
but you can absolutely envision
Yeah,
people
yeah,
saying,
sure. In
well,
the real world. Yeah.
yeah, and I don't, you know, I don't, again, I don't know that there'll be a randomized trial, but
Mm-hmm.
you can imagine a cohort of patients who get neoadjuvant therapy, don't
Mm-hmm.
get the adjuvant portion, who are ctDNA negative. If you
Mm-hmm.
follow those patients and they do really, really well, boy,
Mm-hmm.
it's hard to argue that they should have gotten
Yeah.
therapy. Again, I don't know that
Yeah,
we'll
yeah.
ever have a definitive answer to that, but I think data sets will start coming out of,
Mm-hmm.
people who do that and keep track, and, single arm cohorts, things like that.
Okay, so the next question is that what is your preferred interval and also the frequency for the ctDNA testing when you during your decision making
Yeah,
for the
I don't
adjuvant
know that I have an
immunotherapy?
established pattern. I think probably,
Mm,
checking it with each CT scan makes sense to me. Like every
okay,
3 months, I'd probably do scans
three
every three
months.
months in the
Okay,
first year after
no, not
cystectomy.
according to the in bigger
No,
one
doing it
or
every
first
six
go no.
weeks, and I mean, that's a pretty big
Hmm.
burden. I'm not sure that
Yeah.
there's the advantage of getting it every 6 weeks versus 12 weeks.
Hmm.
You'd be hard pressed to convince me
It's
that,
very
first of all,
costly.
I don't think that it was a relatively small percentage of patients that turned
Hmm.
positive in that year, right? I don't
Hmm.
remember the number.
Yeah.
And so
It's
starting their
it's a
therapy
very
six
small
weeks later,
proportion. Yeah. Mm-hmm.
you'd be hard pressed to convince me that a delay of therapy of 6 weeks really impacted outcome.
Okay.
It's not really
Yeah.
believable. So
Yeah, I agree
this
with
is
you.
just, many patients at our center, and I'm sure at your center, travel a couple hours to see us. So to make them come back and forth or get a blood test
Mm-hmm.
every 6 weeks versus I would probably just do it when I see them for scans.
Not so practical.
Yeah, I would tend to be more practical about it. Yeah.
Okay. So another more, I think, more technically issue or the question is that how do you define and interpret the ctDNA abundance? It remains, to be there's a lack of the standard when there is abundance or standard. We can see that you have a positive ctDNA because right now the technique is different and also it's very different from US and also here in China. And we also there are different technology. We use the VAF or there are several companies or several techniques we use the cancer cell fraction. And so is there a standard or what's your preferred, for the interpret for the ctDNA results?
Yeah, I mean, I think I would just stick to the Signatera definition from InVigor 11. I think they
Mhm.
had
Okay.
two out of,
Okay.
I think it's 16 mutations. I don't quite remember the denominator
Mm-hmm.
of how many
Mm.
mutations they test for, but
Yeah.
yeah, I don't have a different definition. Again,
Okay.
I tend to stick to the data from the clinical trial, so I'd probably use that
Okay.
definition.
Okay, so it remains a no. So we can maybe there leaves us as a lot of work to do, to build or set a standard for the clinical practice. I think.
Yeah. Yeah, and I think, I don't know that different definitions would be that important, and I think that's the
Mm-hmm.
nice thing about ctDNA is there's not a lot of interpretation. I
Mm-hmm.
do work in kidney cancer and RNA gene expression. That's much more
Mm-hmm.
complicated. And,
Yeah,
what
sure.
is this group or that group? That's much more complicated.
Mm.
This is pretty
Yeah.
binary. Like it's
Mm-hmm.
either detectable or it's not. And
Sure.
I haven't heard a lot of discrepancy about patients who are sort of positive
Yeah.
or
Yeah.
false positives or anything like that. I
Mm-hmm.
don't think that
Mm-hmm.
exists to any great extent.
Yeah, but also there is a limit, to detect the ctDNA when it is
Sure.
low than the limit, and but the limit seems to be, to be could be changed, it's rely on the different technology and also it may be
Yep.
different from centers to centers.
Sure. Yeah, I think there's some variability. I've not heard a lot
Mm-hmm.
of, uh, you know, noise around that being a big issue,
Mm-hmm.
though.
Mm-hmm.
I think it's pretty well established and pretty
Mm-hmm.
binary in terms of you're either positive or not. And
Mm-hmm.
I've not in practice, although I've not used it a ton yet, run into patients where the test is ambiguous or this. And so, I don't think that's going to be the issue. I don't think the test itself
Okay.
will be the issue.
Okay.
And, I suppose as we develop more sensitive
Mm-hmm.
ctDNA tests,
Mm-hmm.
I guess you could ask the question, well, is any bit of ctDNA detectable the same,
Okay.
Because right
Mm-hmm.
now we have a
Okay.
certain threshold.
Yeah.
If we lower that
Mm-hmm.
threshold and can detect smaller and
Sure.
smaller amounts,
Sure.
is that the
Mm-hmm.
same biology?
Mm-hmm.
Is it just yes, recurrence for those patients and no or not? Or if you're detecting super minute fractions, are those patients really at risk? I suppose that'll be an area where we sort of get into as these tests become more sensitive, presumably.
Sure.
I'm not sure that's the most important area of research for ctDNA. I think how do we apply it in clinical practice? What do we do if you're negative
Yeah.
after,
Yeah.
neoadjuvant EVP? What do you do
Yeah.
if you're negative after neoadjuvant EVP before cystectomy,
Mm-hmm.
right? Like,
Yeah.
that's a big
It's a very
area is can
interesting
we avoid
question. Yeah.
cystectomy in a subset of patients?
Sure.
And, again, there's no data, there's no randomized data. Certainly, there's some
Mm-hmm.
single arm data that Matt Galsky published a couple years ago. So
Mm.
I think we're about to enter a really interesting period where ctDNA will be part of, integration in these
Yeah.
patients.
Yeah.
I'm not sure the more sensitive ctDNA is that important, but I don't know. I hadn't
Mm.
really thought about it, but I think it'll be part of the picture for sure.
Okay. Okay. So let's moving forward into the second part, and we are talking about the neoadjuvant therapy, neoadjuvant setting. I think the neoadjuvant therapy it's like a mid ground when our urologist and our medical oncologist we should meet in the neoadjuvant therapy. We should talk and we should discuss more about neoadjuvant therapy. So my first question is that with all the result and for the positive result of the EV 304, just I think maybe the 2 or 3 days before, and we have
Mhm.
received the positive result, and also with the positive result of the EV 303 studies. So would you change your first line preferred neoadjuvant therapy regimen for the MIBC based on these trials? And we use more EVP, in
I
the
mean, we'll use
MIBC as the neoadjuvant
exclusively. We'll use
exclusive.
exclusively
Okay.
EVP. I
Mm-hmm.
mean, there
Mm,
aren't many. The
mm,
beauty of it also is that there aren't many patients who
mm,
can't get it. There were a lot
mm,
of patients who couldn't get cisplatin for a variety
mm-hmm.
of reasons, renal function and
Mm.
otherwise, right? I mean,
Sure, sure.
probably,
Mm, sure.
30, 40, 50% of the patients couldn't get
Okay.
or
Okay.
and or didn't get neoadjuvant cisplatin-based regimens. With EVP, though, I haven't really had that
Mm-hmm.
experience. I haven't run into too many
Mm,
patients, if any, where before giving it, I said,
mm-hmm.
"Oh, this patient can't
Mm,
get it."
mm,
Of course,
mm,
there are absolute contraindications to immune therapy and such, but
mm-hmm.
it's pretty darn rare,
Mm-hmm.
and you can dose adjust the EV, and there's ways to give it. So
Mm-hmm.
for us, every single patient is going to get it.
Mm-hmm.
It's so active. The urologists are on board with this. I think they were less on board with cisplatin gemcitabine because it took,
Mm-hmm.
decades of work and meta-analyses to say, yeah, there's probably a little
Yeah.
benefit. It wasn't
Yeah.
wasn't really that exciting, let's be honest, right? But
Okay.
this is exciting,
Mm.
right? And this
Yes,
is
sure.
definitive survival advantage now in two
Yeah.
randomized trials. No
Yeah.
question about it. Nobody's questioning the results. Nobody,
Mm-hmm.
it's a slam dunk, and we don't see that very much in
Mm-hmm.
our field, right?
Mm.
Once or
Sure.
twice in our
It's a
lifetime.
breakthrough.
So,
Yeah.
so I think
Mm-hmm.
this is very clean, and I think it's going to be our go-to regimen. And again, I think there'd be very few patients who wouldn't get it.
Okay. So in your clinical practice, you were excluded all these patients from the cisplatin and the gemcitabine if there is no contraindications from the EVP. Yeah.
Yeah, I can't imagine giving a
Okay.
patient Gemsys. I
Okay.
don't.
Okay.
Because if
Okay.
they
Okay.
can't, if they couldn't get EV, I suppose, the only patient who might get Gemsys
Yeah.
would be somebody with an immune therapy absolute
Yeah. Sure.
contraindication.
Okay.
That's a
Okay. Okay.
Because if they can
Okay.
get Gemsys, they can get EV, right? I, you
Yeah.
know, I,
Okay.
I suppose they could have some terrible neuropathy or something, but I don't,
Mm,
again, I think
mm,
we're talking about rare individual patients here, not large
okay.
populations. So I
Okay.
think it'd have to be somebody with,
Mm, mm,
I don't, whatever
mm.
terrible ulcerative colitis or rheumatoid arthritis, so and that's out there.
Yeah.
But again, I think that's pretty rare. I've not come across that much.
Okay. Yeah. So the second question for neoadjuvant therapy is there a current role, for the molecular markers, like molecular subtyping or you using some biomarkers to predict, to select these patients from the neoadjuvant therapy right now in your clinical practice?
No,
And what's your point
no,
of view?
I'm not aware of really data about selecting patients. Again, I
Okay.
think
Mm-hmm.
sort of when you have, I think we need biomarkers in every area of cancer, of
Mm-hmm.
course, but you need them a
Mm-hmm.
whole lot more when you have less
Mm-hmm.
effective therapy, right?
Mm-hmm.
When we're
Okay.
giving, BEP for germ cell, we're not talking about biomarkers. We just give it because it's really effective,
Yeah, yeah, yes,
right? And I'm not saying
it's
EVP is like BEP, but it's,
mm,
when a regimen is so effective,
mm,
the need for biomarkers is less and less.
yeah,
I think
yeah.
the biomarker will come in if we're trying to avoid cystectomy in a subset of
Mm-hmm.
patients, the need for
Hmm.
adjuvant therapy, like we talked about, et cetera, not so much selecting the regimen, but how to implement the regimen in practice. I could see
Yeah.
that area developing, ctDNA
Mm-hmm.
and other biomarkers.
Yeah.
But in terms of selecting the regimen, I
Mm-hmm.
don't, again, to me, the data is so compelling. Now,
Okay.
as other data comes out and maybe there's, you know, DV toripalimab does a neoadjuvant study, and
Mm-hmm.
well, that's biomarker, but you can imagine that we'll, over the next 5 to 10 years, get into
Mm-hmm.
situations where EVP is not the only regimen and we're
Mm-hmm.
selecting between 3 or 4 really good regimens, and maybe
Yeah,
some are
yeah,
HER2 directed and some aren't, or whatever,
yeah.
and I could see that developing, but today I don't think that's the case.
Okay. So another question is that the variant histology. We have several
Yeah,
data, according to, I think, in the EV302 setting, in the metastatic
yeah,
urothelial carcinoma, we have some variant histology data. It seems that, okay, it depends on the proportion of the variant proportion, whether it's a
yeah,
var it's a urothelial predominant, or it's a variant predominant. If it is a variant predominant, it seems to be a low rate of response to the EV, to the EV treatment, and it seems to be there is a zero of the response rate in the neuro-like and any-like in any-like variant. So
yeah.
what do you so in your clinical practice in the neoadjuvant settings, what do you change if the patients always have the variant histology?
Yeah, I think it depends on the percentage. I think what I tend
Yeah.
to see a lot
Okay.
is, oh, there's,
Mm-hmm.
10% squamous features or 10%, it's
Mm-hmm.
not predominant. It's a little, 10 to 20%. And I would still give
Mm-hmm.
them EVP because I think the
Okay.
data is still
Okay.
compelling.
Yeah.
Obviously,
Yeah.
we've not seen the data from the neoadjuvant
Mm-hmm.
trials to know exactly about variant histology. I don't remember if it was
Mm-hmm.
presented at ESMO. I don't think so, but I don't quite remember. But
Mm-hmm.
my default would be still to give EVP to those patients.
Mm-hmm.
However, like I saw a patient yesterday in clinic who had, pure small cell of the bladder,
With the
muscle
small cell,
invasive
yeah.
small cell non-metastatic. And so I would give that patient, carboplatin etoposide, with
Yeah.
or without
For the EP.
atezo.
Yeah. Mm-hmm.
Yeah,
Mm-hmm.
so that I think is a different, as you say,
Mm-hmm.
that makes
Mm.
sense to me. If
Okay.
it's like a pure adenocarcinoma, I don't know.
Mm.
I mean, the hard part is it's not like there's great regimens for that.
No.
It's not like there's
No.
like you can pick a generic adenocarcinoma regimen, but
Yeah.
that's not very exciting, and it's not, you know what I
No.
mean? So I'm not sure. I'd like to see the data more around variant histology from
Mm-hmm.
the neoadjuvant trials.
Yeah. Okay.
And
Mm.
I don't know that
Mm-hmm.
we've seen that data. We certainly haven't seen any data from 304 yet,
No.
but I don't know that in the presentation of 303 that Christian talked a lot about variant histology. I don't remember it from the presentation, and I don't think there's a manuscript yet. So, I think that's the kind of detail that's important because we do see it in
Okay.
practice, even if it's, relatively rare.
Yeah, yeah. It's like with the urothelial carcinoma with squamous variant. It seems to be more like it's not so rare, and we can see it frequently. We can see it in clinic frequently.
Yeah,
So
I
so
think we
maybe
definitely see it. It's
yeah.
usually, at least in the US in my practice, it's
Mhm.
not predominant squamous. I'm not seeing a lot of that. I
No.
know in other parts of the
Yeah.
world
Yeah.
they might, but
Mhm.
we're seeing urothelial with, some
Mhm.
squamous different dedifferentiation or,
Yeah.
something.
Yeah.
It's kind of like a little tail on the pathology report that we
Yeah.
see. And
Mm.
it's notable, but it wouldn't impact my practice. If it's
Okay.
100% of squamous or small cell, then I think it would. But I still
Mhm.
think we need more data to know, to be honest.
Yeah, but in the era, before the EVB, the result of the EV303 in the era of the neoadjuvant chemotherapy, it seems to be the molecular subtyping. We can
Hmm.
help us, for the deciding which patient should receive the neoadjuvant chemotherapy, for the with the squamous differentiation, maybe this is basal squamous subtype, maybe they could be lead to the resistance, to the to the chemotherapy. But
Yeah.
it just as you said, right now in the era of the EVP, we still don't have so many data in the neoadjuvant chemotherapy,
Yeah, I agree. When we were
neoadjuvant
giving
data.
GemCis and it was like pure squamous, we just take those patients
Mm,
to cystectomy because we
yeah,
didn't think our chemo would do much.
no,
Again, I think it was relatively rare,
yes.
but I
Mm-hmm,
agree. I think we have to rethink it, especially given the survival benefit and all
mm-hmm,
that. I think we need to rethink it. And,
mm-hmm,
you can imagine people doing
mm-hmm,
trials
mm-hmm.
in variant histology specifically to get
Yeah.
more data. That seems wise to me. So
Mhm. Yeah, I totally agree with you. So the third question is about look at the biopsy in the neoadjuvant therapy in MIBC. So we're talking about the UTDNA first. So we can see there is several data, for the ctDNA in the neoadjuvant chemotherapy and the and also in the Niagara study and with the perioperative, the immunochemotherapy neoadjuvant settings. And but we still don't have so much data of the ctDNA in the EVP. No, I think we don't right now. We still don't have any data for the
for the
EVP
neoadjuvant, no, I don't
neoadjuvant.
think we've seen.
No, yeah, no, I
I,
see.
I
So
assume we
what's your
will,
point of view? Mm. So what's your point of view? So is there currently some trials? I think it's running, or is the EV303 or the EV304 have the Codex trial of the ctDNA? No,
I'm
I
sure
think
they collected ctDNA. I don't think it's been
okay.
reported.
Mm,
So,
mhm,
my guess would be, I mean, we saw it with Niagara. I think that was at ASCO or ASCO GU.
mm,
I think EVP
mhm,
is a more potent regimen.
mhm,
So, my guess is that a whole lot of people are going to be
mhm,
ctDNA negative even before cystectomy. I mean,
mhm.
the path CR rate was 57%.
Yeah.
So I would guess those
Mm,
patients would be
mm.
ctDNA negative, right?
Okay.
At least most of them, maybe all of them, and then probably some other patients, who have a
Yeah.
little bit of residual disease in their bladder, but not
Yeah.
enough to be in the circulation, right? So, and again, that's going to open the question of do we really need to do cystectomy in all these patients who are, path CR and
Sure.
ctDNA
Mm-hmm.
negative, right?
Mm,
Separate
mm,
question, but important. So yeah, I think, if and how to integrate
mm,
ctDNA in the neoadjuvant EVP world, we don't know yet.
mm.
But
We don't
I'm
know.
going to
Okay. Mm,
guess in 2026 we're going to see a good chunk of data.
mm-hmm.
Maybe not at ASCO GU, but
Mm-hmm.
ASCO and ESMO. I'm guessing we're going to see a good chunk of data
Mm-hmm.
that's going to inform and really, start some of those conversations we had early in
Mm-hmm.
this podcast about do you really need the
Yeah.
adjuvant and who are you giving it to? I think we'll start to see
Yeah.
that, but clearly we need data first, right? And so until we have data,
Sure.
I would give the regimen as given in those studies. And
Yeah.
even if I
Yeah.
collected ctDNA, I would still
Mm-hmm.
give the regimen. I'm not generally a fan of getting a test and not doing anything with it.
Okay.
So I, I wouldn't do it unless it's going to change my practice. And right now,
Mm-hmm.
it wouldn't change my practice.
Okay.
I would give it as in the trial unless there's some toxicity or other reason, right? So,
Yeah.
but if we're sitting here a year from now, I think the answer will be
Mm-hmm.
different because I think we'll have more data.
Okay. So the next question is the urinary tumor DNA, the UTDNA. What's your point of view in the
Yeah,
of the
I don't. I mean, there's
UTDNA
much less
use?
data. There's
Mm-hmm.
much less data for
Okay.
UTDNA. I don't have any experience personally in my practice in doing it.
Mm-hmm. Mm-hmm.
I think that's going to come in, when we're talking about bladder sparing approaches.
Yeah.
Is there a population of patients we can give neoadjuvant EVP
Mm-hmm.
to their path, their, TUR, their bladder is clean by MRI and
Mm-hmm.
cystoscopy, their ctDNA is negative, their UTDNA is negative, and what
Mm-hmm.
happens to those patients?
Yeah.
Clearly it's more relevant to what's happening in the bladder, and it's another measure
Yeah.
aside from
Sure.
cystoscopy or MRI or however you're assessing the bladder. Or if patients are only UTDNA positive, can they just
Mm-hmm.
get some sort of intravesical therapy, right? There's now a litany of intravesical therapies that have been
Sure.
approved in the non-muscle invasive space that, boy, it makes a
Sure.
whole lot of sense to
Mm-hmm.
me. If I'm a patient, I don't want my bladder out,
Yeah.
just give me one of those intravesical therapies. Again, I'm not
Sure.
saying there's data to support that, but sort of taking the patient friendly sort of view, boy, that makes a whole lot of sense to me. So I
Yeah.
think again we're just at the beginning of that journey, but I think we're going to start to see approaches, a lot more bladder sparing approaches than we have in the past.
Yeah, sure. So, because our team have just several studies, around about the UTDNA practice and in the not only in the neoadjuvant therapy in MIBC and also for the bladder preservation therapy in MIBC. I think maybe later I will send you our paper and our
Sure.
results and we can have further discussion. So let's moving forward to the third part and the last part of our conversation here is the preserving therapy. It's always fascinating, for all the patients with diagnosed with MIBC. All the patients want to have their bladder intact. So
Yeah.
for these patients and with just as you have mentioned, right now we have several tools, we have several fascinating regimen with EVP, and we can achieve a very high ratio rate of the pathological response for these patients. And we also have ctDNA. We can find these patients with negative ctDNA, which has a very good prognosis, and we can see there is a rare recurrence and a rare metastatic status. So whether, right now the traditionally the modality, the TMT treatment would be changed, with all these tools and all these new regimen. What's your point of view?
Yeah, I mean, I think the neoadjuvant EVP data really does change that conversation, right?
Okay.
Because,
Sure.
there's not data for doing that and then doing,
Mm-hmm.
you know, bladder irradiation, right?
Mm-hmm.
And the EVP data is so compelling, it's hard not to do it, as we talked about.
Yeah.
And I think, although we don't have the definitive data today, I think EVP will be part of bladder sparing approaches, right?
Mm-hmm.
There'll be a
Mm-hmm.
subset of patients. I don't know if it'll be big or small, but I think on the bigger side who
Mm-hmm.
can get away without doing cystectomy and can get,
Okay.
that's their
Sure.
bladder sparing. So
Mm-hmm.
I don't know what the role of radiation is going to be. And is there going to be studies that give neoadjuvant EVP and then do bladder sparing with radiation? We haven't seen those studies. Maybe they're
Mm-hmm.
planned. I'm not aware of them, but that makes a lot of sense to me. So I don't,
Sure.
I think the days of sort of just routine trimodality therapy, I think is really challenging.
Mm-hmm.
I think
Okay.
we have better tools now.
Mm-hmm.
We can do better
Yeah,
for these
sure.
patients, and we shouldn't put aside really effective systemic therapy to just do trimodality therapy. We do it. We do it in our center a fair amount, and as the
Okay.
medical oncologist, I'm giving the little bit
Mm-hmm.
of chemo, but it's usually patients who just can't get cystectomy and they're too old and they're too
Ah,
sick. And so,
yeah, yeah.
it's not young, at least in the US and in our hospital, it's
Mm-hmm.
not young, healthy patients who are getting trimodality therapy. It's the older
Okay.
and frail patients.
Okay. Okay.
Now,
So
that's not
it's
true in Europe.
eligible. It's
In other
unfit
parts of the
for the
world, they do
radical
it much more
cystectomy
commonly.
patient. Yeah,
In
yeah.
other parts of
It's
the
all
world, they do it much more commonly. So I think the
mm,
places that do it more commonly, I'm guessing will
mm,
think about studies that are going to integrate more effective neoadjuvant therapy.
sure.
In my opinion, they should. It's
Mm,
hard. Again, it's hard to
yeah.
say to a 52-year-old patient, well, I'm not going to give you
Mm-hmm.
neoadjuvant EVP with this
Mm,
massive survival
mm,
advantage and do
mm-hmm.
trimodality therapy. I think that's a hard
Mm-hmm.
conversation. So again, we don't really have data either way, so we just need to do those trials.
Mm-hmm. Yeah, sure. And because here in China, it seems the patient seems to be more, more comfortable or acceptable, for to receive this chemo-free chemo-free regimen rather than they receive the chemotherapy. I think maybe like the EVP combination with the radiotherapy, or right now we're also doing clinical trials. We are using the DV, the DV in the HER2 overexpression MIBC patients to replace the chemotherapy. I think maybe that will work in the future. I think maybe there is clinical trials. I think using the EVP and with the radiotherapy as a phase 2 or phase 3 trial. I think it's just recruiting or just
Okay.
running. I think, yeah, maybe
Yeah,
maybe
I'm not
we are
aware of the
work.
details, but again, it makes a whole lot of sense. I think you're gonna have to do it, or else that modality is going to be infrequently used, I think.
Yeah, sure. And I think maybe they also bring more questions, for these patients who received the bladder preservations therapy because for the neoadjuvant therapy, we just will decide, like, after 3 or 4 cycles of the neoadjuvant therapy, you'll have the radical cystectomy. But in the bladder preservation settings, it seems to be more complicated, you know, so how many cycles you should receive, and
Yeah.
how long the period of the treatment should have, and how long should the immunotherapy should last, 1 year or 2 year.
Yeah.
It brings us just more questions, to
Sure.
answer.
Yeah, I agree.
And yeah, and the second question is that, so whether in your clinical practice right now, we still lack of the chemo-free bladder preservation strategies. So in your clinical practice, for this patient is unfit for the radical cystectomy. So would you just recommend the radiotherapy alone, or the radiotherapy plus, plus to the
We,
immunotherapy, yeah,
um,
as replace, because there are several patients is unfit for the radical cystectomy. Maybe there is also cisplatin ineligible for this patient.
yeah, I mean, we generally give some form of chemotherapy if we're giving radiation, if we're doing
Okay,
trimodality
okay,
therapy. We
okay.
might give low dose gemcitabine or other regimens, if they're less fit. And
Okay.
again, these are less fit
Mm,
patients in general.
okay.
I'm
Mm-hmm.
not necessarily convinced that the choice of chemotherapy in this setting is super critical.
Mm-hmm.
So some of it's convenience
Mm-hmm.
based or
Mm-hmm.
comorbidity based, et cetera.
Yeah.
Again, we don't do a ton of it.
Mm-hmm.
Now, in the US, there's
Mm-hmm.
just not a lot of it,
Okay.
and I have a handful of patients, but I'm not sure
Mm-hmm.
that's critical. But
Mm-hmm.
I
Mm-hmm.
don't know that I have too many patients who just got
Mm-hmm.
radiation. They'd have to be
Yeah.
pretty sick to just do that. And then you have to start to question, what are you
Mm-hmm.
even treating, if they're that sick from other things.
So, and also, a question, the third question is that, so we all know that the result for the retain trial, the retain 1 and the retain 2 trial, and also there is a group using the sequencing, using the DNA sequencing to decide whether the patient is with tumor is with the DDR mutated or DDR wild type. For the retain trial.
I don't.
The written trial. I think it's the published maybe in the this year in the
Okay.
ASCO GU meetings. Yeah, there are the researchers, they will test the tumors to see whether the patient is with DDR mutated. If the patient is DDR mutated, they will receive the chemotherapy, they will receive the immunotherapy, and then they will go to the active surveillance, no radiotherapy.
Okay.
So they will decide whether the DDR mutation is
Hmm.
related, to the complete response for these patients. So it seems that there is several clinical trials is right now is designed just like that. We're using the biomarker, or using several biomarkers guided or the derived clinical trials design. And I just want to ask, what's your point of view, for this clinical trials design? Right now we have several biomarkers and potential biomarkers, like this. One is the liquid biopsy. We're using the ctDNA guided or the utDNA guided, and another is the tumor tissue based
Yeah.
biomarkers.
I
What's
mean,
your point of
listen,
view? Yeah.
I'm all for biomarker-based treatment. I'm all for biomarker-based trials. I think they're super important across
Okay.
diseases, GU and
Mm,
otherwise.
mm, mhm,
Again, I think with EVP on the scene and its activity, I think we're going to have to rethink doing that,
mhm,
you know,
mhm,
and and I see a transition from bladder sparing, which meant
mhm,
trimodality therapy of
mhm,
TUR and
mhm, mhm,
mostly radiation and a little chemo, to bladder
mhm,
sparing being neoadjuvant EVP and
mhm,
some intravesical
mhm,
therapy. So I think the term
mhm,
bladder sparing is going to mean something different, over the next few years.
mhm,
So if I was giving advice to a junior investigator who wanted to build a
mhm,
career in traditional
mhm.
trimodality therapy, I might
Yeah.
say you might want to rethink that. You might want to
Yeah.
rethink that because I think the landscape's about to change dramatically. And again, it's not
Mm-hmm.
that there won't be patients or won't be important, but I think we all just need to take a step back and
Mm-hmm.
think about,
Yeah.
what are the tools we have? How do we do the best for our patients? And how can we spare a
Mm-hmm.
subpopulation of patients from cystectomy? I
Mm-hmm.
don't, their cystectomy's, still the standard of care in muscle invasive
Mm-hmm.
disease, et cetera,
Mm-hmm.
so we're not saying it's
Yeah.
not,
Yeah.
but I think we're going to start to rethink that. But we need data to support it. I don't think we can
Yeah.
just make a switch,
Sure.
flip a switch and do it. I don't think that's appropriate either. We need to do the hard work to say who are those patients, and maybe some of that's biomarker selection. Again, I think it'll be
Sure.
circulating in urinary tumor DNA, among other things.
Okay.
But it opens up a lot of avenues, but we have to think differently.
Okay. So the last question is to just imagine, with all we have mentioned before, just imagine we have a patient we have which have received the EVP regimen as the neoadjuvant settings, and then the patient just waiting for the radical cystectomy, and we'll have ctDNA imaging. Just imagine this patient with positive ctDNA but negative utDNA. What do you suggest this patient to receive the
I
radical
don't know.
cystectomy?
I mean, we don't know, right? There's no data,
We don't know. Yeah, we don't know.
which would beg the
It's a,
question,
it's, it's a tough it's
why
a
are we
tough
checking
decision,
it? Right? We're
Yeah,
we're creating anxiety. I mean, unless you're going to say, gee,
yes.
this patient
Mm.
shouldn't go to cystectomy, they should keep getting
Mm.
systemic therapy, which
Mm-hmm.
would
Mm.
be the hypothesis, but there's absolutely
Mm.
no data to support that.
Yeah.
Um,
No.
it's
Mm-hmm.
um, in the Niagara trial, I believe about 10%
Mm.
of patients became ctDNA negative after cystectomy,
Mm-hmm.
an additional 10%, 8, 9,
Sure, sure,
10%,
sure.
something like
Yeah,
that.
yeah. Yeah.
Now, again, you could argue, well,
Mm-hmm.
those are tumor cells in their bladder. Or so I don't know. We don't
Yeah,
really
yeah.
know, right? We don't know the source per se. So
Yeah.
I don't know. But
Mm-hmm.
again, I think over the next year and years, we're going to
Mm.
start to see data of these different subsets and what do you
Sure.
do and what's their natural history and what happens, but
Mm-hmm.
right now, again, I think we don't want to stray too far from what the proven benefit is and start doing things based on a
Mm-hmm.
test and we're not sure how to use it. And again, I don't send tests that I'm not going to use, so I wouldn't send it in this setting. I
Okay.
wouldn't. I wouldn't. I don't know because again, what if, like you say, what if they are persistently positive? It doesn't mean they shouldn't
Mm-hmm.
get cystectomy and adjuvant therapy as
Mm.
per 303 or 304, right? It doesn't. We
Yeah.
don't we don't have the data to say that it doesn't. Now, if data comes out that yeah, those patients do really poorly and
Mm-hmm.
they all relapse with metastatic disease, okay, well
Mm-hmm.
that's totally different, right? Now there's a really good reason to do it.
Mm-hmm.
But until and unless we have that data, I'm very hesitant
Mm-hmm.
to overinterpret, and start doing a bunch of tests and doing it,
Mm-hmm.
I'm not sure we're doing
Mm-hmm.
patients favors by doing that.
Sure. So
Yeah.
there's still another argument that exists in China. It seems that if the patients, just as we all know that the patients with persistent ctDNA positive, it seems to be a very worse prognosis. There is the argument in China that these patients it will still have worse prognosis, whatever if he received radical cystectomy. So why not we just give it's the question is more about which kind of systematic therapy he should have received rather than whether he should receive radical cystectomy. What's your point of view?
So you're saying somebody who's persistently ctDNA positive, you'd switch their
ctDNA
systemic
positive
therapy?
after the neoadjuvant
I mean,
therapy.
again,
It is
it's a hypothesis. I don't
yeah.
disagree, but there's no data. There's no data to
Yeah,
support
no
it, right?
data, no data.
So, again,
Yeah, there are several urologists say that maybe this patient is only if he received the right systematic therapy, but not the radical cystectomy. The radical cystectomy maybe there is no benefit
I
for
mean,
these
I
patients.
don't disagree with the
Yeah,
hypothesis, but I think I'd want to see some data
yeah, yeah,
to
yeah.
prove it.
Okay, yeah.
I think we will, right?
Mm,
I think we'll start to
mm,
see these data sets come
sure.
out or single arm trials. I don't know about big randomized
Yeah.
trials, but
Mm, mm,
it's nice to have some data to say, yeah, these patients, invariably relapse. Well, then
yeah.
absolutely don't put them through a big
Yeah.
surgery. I'm all for that approach,
Yeah.
but we don't have that data yet. And so are you, Are you foregoing cure in a subset of patients who could be cured? That's a big deal. And I
Sure.
think the burden of
Yeah,
proof is to prove that another
sure.
approach is safe and effective, not to assume that it is.
Okay. Okay. So thank you, Professor Rainey, for your
Sure. Thank you.
intakes and also practical insights throughout all these conversations. So today we have developed into three core areas of the MIBC management: the adjuvant therapy, the neoadjuvant therapy, and also with the blood preservation therapy. So the Brian, would you mind, to leave a message, to the Chinese oncologist and also the urologist about all we talked today
I mean, I think the
as a
take home,
conclusion, as a conclude. Yeah.
yeah, the take home is that, the peri-operative or maybe even more broadly, the management of muscle invasive bladder cancer is about to change dramatically, right? EVP and maybe similar regimens will be the standard of care. Integration of ctDNA, I think, is still a work in progress in UTDNA. I think we're going to move away from big cystectomies in a large subset of patients. If and how to do that and how to select patients, though, we need to be careful and do the right studies. So we're not foregoing curative treatment in that, subset of patients. But it's about to change dramatically, and we're going to basically have to start over in a good way, right? It's a good problem to have, right? We have
Yeah, it's a
such
good
active
way. Yeah.
systemic therapy that is a good problem of how do we integrate it, and can we use that to
Sure.
spare some people, other toxic therapy or surgeries.
Mm-hmm.
But I
Mm-hmm.
think it's going to change. It is changing dramatically.
Yeah, yeah. We are moving more forward into a new era.
Yeah,
Yeah. So thank you again, Brian. Thank you, Professor Rainey, for your
my
valuable time
pleasure.
and profound sharing.